Dr. Braga is giving a talk today about prenatal hydronephrosis. So I'll be moderating. If you have any questions, feel free to ask in the chat, and we'll go from there.
Good afternoon, everybody. It's a pleasure to be here with you guys. First of all, I'd like to thank the University of California, San Francisco for this wonderful opportunity, and also to congratulate them, and especially Dr. Lindsay Hampson for such a great initiative of having this COVID lecture series. So the topic today, we're going to talk about prenatal hydronephrosis. I'll try to limit my talk to 40 minutes, maximum 45 minutes, so Ding will cut me off so that we can have some time for questions. It is a controversial topic, but I'll try to attain myself to some guidelines and what Campbell's textbook of urology and what you need to know, the basics for exams and at least for the rotation in pediatric urology. So then we'll talk about the background and definitions, indications for the workup of those patients, management, and some guideline reviews. So two things are very important to start is to differentiate between what is considered a hydronephrosis and congenital renal obstruction. So pediatricians, primary care physicians, they get this confused, and I think it's important to have this clear in mind. So hydronephrosis is an ultrasound finding. So it just means that you have dilation of the renal collecting system. On the other hand, congenital renal obstruction means impaired urinary drainage, which, if left uncorrected, will limit the functional potential of that developing kidney. So therefore, in face of obstruction, you have to probably indicate surgery to try to correct that obstruction and then alleviate the kidney and allow the kidney to grow and develop. So far, and that's the difficult part in pediatric urology, no single test or investigation can prove renal obstruction. And we'll try to show you guys how we do it and what strategies we use to try to make this diagnosis. So a little bit of epidemiology and background. So a UTD, urinary tract dilation, is very common, one of the most common findings seen in conditions in pregnancies. So depending on where you read, it's up to 1 to 3% or even 5% of all pregnancies. In the US alone, it's responsible for almost 80,000 children per year. So this is typically seen in the second trimester. And then because at that point, you have some maternal indications for like checking for Down syndrome or any other amniotic fluid that it needs to be checked. And then at that point, they do an ultrasound and they will see it. But basically, most cases of antenatal hydronephrosis, they will resolve spontaneously, even though it's very prevalent, but the overall majority is physiologic and will resolve and cause no problem. But a wide range of uropathies are possible, and we'll try to talk a little bit about them. So it is important to identify the pathology prior, of course, to the development of UTI. Some conditions will have a higher risk of UTI than others, development of stones or symptoms, and also, of course, renal dysfunction with worsening of the hydronephrosis and loss of kidney function. So when we look at the consensus, when we look at the consensus statement for antenatal hydro, what we see here is that the most common, as I mentioned, the condition is called transient or physiologic urinary tract dilation, and this can be seen in up to 50 to 70% of the cases. After that, we have more specifically what they call UPJ pattern dilation, or I like to call UPJ obstruction-like. It's like an obstruction, but we haven't defined yet because it's difficult. Sometimes you need serial ultrasounds or a renal scan to define, or more than one. So this can occur in 10 to up to 30%. Then the third most common cause is vesicular reflux, which also varies, and we'll show you guys why this range can go from 10 to 40%. Then more uncommon is like a UVJ obstruction. So the whole ureter is dilated, but there is like an area close to the bladder insertion. MCDKs in 2 to 5%. The duplication anomalies, ectopic urethral seal, up to 5 to 7%. And then severe conditions such as Pruny belly and posterior urethral valves in maybe 0.5% of the cases. So how do we know who to follow and who to treat? So there is a large variability in clinical practice patterns and recommendations. And then that's why it makes it a little bit difficult for pediatricians or primary care physicians, and also for the new coming or incoming urology residents, for even fellows when they're starting, and then for nephrologists. So in the US, the evaluation of a child with antenatal hydronephrosis is estimated to cost around $100 million and annually. And so this is a great way, or it's a very large expenditure for the healthcare system in the US. So one thing that it's important is that would be the ideal scenario, if you would be able to detect that condition prenatally and then correlate that with a need for surgical intervention postnatally or risk of urinary tract infection later on. So which conditions need to be followed and which not. And as we can see here, there is a poor correlation or evidence with the urological pathology based only on prenatal findings. So maybe this is caused by lack of classification or uniformity, as we will see it. There is inconsistent terminology between what radiologists are using. We have come a long way and we are still making strides, but there is still, how can I say, inconsistency. Specialists, nephrologists are different from the urologists or pediatric urologists. Primary care physicians, pediatricians are different in the radiologists. And also one thing that is important that we have to take into account, that even the position of the baby postnatally or prenatally changes and varies the degree of hydronephrosis, because, you know, urinary tract dilation is a dynamic condition. It fluctuates over time and with the baby, hydration status, etc. So most uropathies represent a spectrum of severity. So it can go from very, very mild cases, and the typical condition for that is posterior urethral valves. You can have a baby with valves that you can see it at age 7, presents to your clinic with urinary incontinence and in the workup of bowel bladder dysfunction, and boom, you go there and you end up finding during the workup that a child had posterior urethral valves. Or it can even have a stillbirth because of very, very early development of oligohydramnios and then pulmonary hypoplasia, and then that baby doesn't make it. So this is a spectrum, and we have to take that into account. So let's talk. I think it's very important for urology resident, because I know in urology, especially in the US, and because you guys, the main condition pathology that you see throughout residency and the main importance is cancer. So you guys get very, very familiar with CT scans and MRs, but I think in pediatric urology, it's still the main driving test that we're going to see it, because it's less invasive. It's not cost very cost expensive, and it's the most common one because it doesn't involve radiation, and also there's no pain or IV related to that. So it's important for you guys to learn the grading systems and be very, very comfortable in making that diagnosis, not waiting and reading reports, because as you see, radiologists may classify or may interpret something in a different way. So what about, there are 3 main grading systems. There are more, but I'm gonna attain to those 3, which are AP diameter, which is the anterior posterior diameter of the renal pelvis. It was started in Europe and mainly developed by the British. So the second one that I'm going to talk about is the SFU, Society for Fetal Urology, which is mainly a North American developing system. And the third one was a combination of those 2, trying to maybe overcome the limitations of the SFU. It's called urinary tract dilation, and was a result of a consensus meeting between all these specialties: radiologists, pediatricians, neonatologists, pediatric urologists, and primary care physicians. So a couple of things here. So the AP diameter, the advantage is that it's objective. It's a simple system and measures the pelvis. The problem here is that we need to be consistent where we're going to measure that. And usually it's at the transverse plane and the mid-level of the kidney, especially postnatally. So a lot of papers have been published and shown a correlation between AP diameter with the severity of the condition and also the need for surgery. So one thing that it's interesting here, and was very frustrating in the beginning when the prenatal ultrasound became a reality in the 80s and the beginning of the 90s, is that there is no relationship between the severity or the grade or the dilation of the anterior posterior diameter and the grade of vascular reflux. So if you have a patient with no hydronephrosis or minimal hydro, that patient can have high grade VUR, as opposed to some patients with no hydronephrosis, like I said, high grade, and other patients with very, very severe hydronephrosis have no VUR whatsoever. So there is no correlation in that part. The second thing is because, again, of those nuances that I mentioned about where to measure, is an operator-dependent test. So it's not like a CT scan or MRI that you have those slices and you can have more reliable or predictable results. And the important thing here is that we have to have in mind is that in the third trimester, if it is the dilatation of the EP diameter is greater than 7 millimeters, according to, again, there is variability, but usually more than 7 millimeters, some would say more than 10, this will indicate or call for a postnatal evaluation, and we'll discuss what needs to be done. So here you have a little bit of some papers or authors have tried to do it. Between 7 to 9 millimeters is considered mild hydronephrosis, 9 to 15 millimeters in the third trimester, moderate, and greater than 15 millimeters, severe hydronephrosis. Oh, yes. So one of the first ones that it's a seminal paper, I think important, by Lee, the group in Harvard. And then what they did was a meta-analysis in 2006, trying to do exactly that, trying to correlate based on the degree of hydronephrosis between mild to severe with the percentage of postnatal pathology. So as you can see here, I'm going to indicate for you guys, we just highlighted two of those, patients with UPJ obstruction. So again, not those who need surgery, but again, most of them would require that, but this is patients who have a little bit more than the transient hydronephrosis. So when you start with mild, the percentage is only 5%, but as you progress and with a degree of hydronephrosis and gets to severe, almost 50% of those patients will have a UPJ pathology postnatally. If this would, all those patients would translate into surgical intervention because they are really obstructed, that's another question, and we'll see that later. As I mentioned before, even with reflux, you can see that the number changed. So patients with very severe had a percentage of postnatal pathology less than patients with moderate one. That was 14 versus 8%. So there is no correlation between the degree or the grade or degree of antenatal hydronephrosis or grade of hydronephrosis prenatally with the postnatal finding of vascular reflux. Posterior urethral valves is interesting because you can see that, again, and this would be a red flag, every patient that has bilateral hydrourethral nephrosis, and this is severe, should be considered as having posterior urethral valves until proven otherwise. And that's why you see that the indications for VCUG later will be there for that population, and specifically to try to negate and obviate those that risk. So going back to this risks, so there I just decided to put two papers here trying to use fetal hydronephrosis as a predictor of neonatal urological outcomes. So this thing about need for surgery, you see that it's not, I don't like the word, but I'm just reporting what the authors described in their paper, because the indication for surgery sometimes may be, not that it's subjective, but may vary from institution to institution or from author to author. So, but what they look at, the main thing here is that patients that had an AP diameter greater than 15 millimeters at the third trimester, they were more likely to have a pyeloplasty as opposed to those that had less than 10 millimeters. So that's an important thing. And we'll see later on that the UTD classification define what is considered normal. And one thing that is important, that patients who have an AP diameter postnatally less than 10 millimeters, this is considered normal. So it's not necessary to do any investigation for those patients. In this case here, these authors decided to do exactly this. trying to look at which parameters or cutoffs would be okay to just monitor patients, and we could discharge them from care, saving the healthcare system some expensive investigations. So they did the opposite. When the AP diameter was less than 20 millimeters and with preserved differential renal function greater than 40%, so what happened here? No patients had to undergo pyeloplasty, and they were followed with serial ultrasounds and showed improvement over the next 2 years. So let's go to the SFU grading system. And so in this regard, what I would like to talk to you about is, because it's classic and you see this all the time, we have SFU grade 1, which is the separation or split of the renal sinus or pelvis. Then grade 2, you have this separation of the pelvis plus the major calyces are dilated. Grade 3, you have what we call, again, dilatation of the minor calyces, but the difference here is that the parenchyma is preserved. And grade 4 is exactly the same as grade 3, but then you have parenchymal thinning. So these cases probably, most of them, I would dare to say that they probably have some degree of obstruction because you already see a compromise of the parenchyma with thinning. So even though, as you see here, it's a 5-point grading system, because I didn't mention here, but 0 would be a normal. It only takes into account the renal pelvis, dilated calyces or calyceal dilatation in the parenchyma. There are other parameters that could be used, such as the ureters and the bladder, that are not addressed here. So, but this one, because it's has been going on or been used in pediatric urology literature for the past 35 years, I believe, 30 years almost. So what happened? This has shown to have a good correlation between patients who have decreased renal function in follow-up, or patients who had to have surgery because of worsening of hydronephrosis or drop of renal or function. So the issues here are the inherent challenges with the inter-rater reliability, especially between grades 2 and grade 3, where the agreement is very poor. Usually it's very easy to differentiate 1 and 4, because people know what is almost normal and what's very severe. So it's almost like different shades of gray. You know what's white and what's black, but you know the gray, you can have more difficulty, so it's not that clear. So I just would like, because I have no idea how many residents are watching, and then maybe you have all different levels, and this is no shame, but I think it's important, and this is an excellent tool that I think all of you, I would encourage to use this. This was developed by Max Mazels in Chicago, and Lurie Children's Hospital there, and he is a very tech a person, and has a lot of, what he developed was that he tried to create a teaching system for exactly residents, but also for pediatricians, so that everybody could speak the same language, and we would try to overcome those shortcomings of the classifications and the subjectivity in interpreting these findings. So this is interactive, and I recommend you guys, this has been published in the Journal of Pediatric Urology, is free access, and you can click, and then the program will color the areas that you're supposed to identify. Sometimes the black and white from ultrasound, people don't have the trained eyes, and they don't see well what is a dilated calyx, what is a dilated major, minor calyx. So I'll try to demonstrate for you. Here we have a sagittal view of a kidney, and this patient has what we call grade 3 hydronephrosis. And the reason for that is because there is preservation of the renal parenchyma. Usually when the cortex or the parenchyma is less than 5 millimeters in thickness, then we start considering this renal thinning, parenchymal thinning. So here they color the parenchyma, as you can see here clearly, that is very thick. Otherwise you'd be seeing a line. So in this part, we can see the minor calyces dilated in blue. Then when you come here, you see the major ones in this area, and then the renal pelvis. So this is very nice, this program. I recommend all the residents to try to use it. And then at the end, he'll give you an exam with 30 cases that you can practice. And then you do your self-assessment, because at the end, the program will teach you your score. And then and also give you the answers why you classify or you grade someone as a 2 instead of a 3 or a 4, etc. So this, it's there for, we participate with Dr. Maisels in the validation or for the SFU and the UTD classification. So talking about the SFU grading system, so it's exactly what I was trying to talk about, because it has been going on for longer, and especially in North America, like Canada and the US, we are very familiar with this classification. We use it, and we have done studies trying to show correlation between the applicability of the classification of the grading system with the outcomes. That's the whole purpose of having a classification, is that we can actually counsel patients and we can publish results and people can interpret our results because they know what we're talking about. So in this paper here, what we saw is that these authors look at 71 cases over 13 years, and patients only have SFU grade 3 or 4. And what they saw is that all patients, this study was done in Chicago, all patients with SFU grade 3 had preserved renal function. So you don't need to be too anxious and try to pull the trigger when you have a patient with grade 3 hydronephrosis, because a considerable amount of patients will resolve spontaneously, even if it takes longer. And why you should not stress too much, because the renal function is stable. As opposed to patients with grade 4 hydronephrosis, as you see here, 27 out of 38 had preserved function, but on the other hand, if you flip the way, 11 out of 38 had already loss of function. So that's the real difficult part in this type of condition, is to try to indicate surgery at the right moment, which is that when patients are obstructed but haven't started losing function yet, instead of waiting too long until they lose function and then you're intervening late. So what's important here is 21% of SFU grade 2 or grade 3 require a pyeloplasty. And this can happen because some of these patients, they show deterioration over time, or they develop symptoms that you have to do the operation, as opposed to 92% of patients with SFU grade 4 who underwent pyeloplasty. So it's not everybody who has grade 4 needs surgery, but according to this paper, the overall majority need it. Some patients do show improvement, but also in my experience, at least 80% to 85%, they have had a pyeloplasty. The other paper here on the side is a paper from Washington, from Gil Rushton, and it's interesting that he showed the same thing, trying to stratify patients, and then they looked at 71 patients with grade 3 hydro and 54 with grade 4 hydronephrosis. And as you can see, only 15% of grade 3 needed surgery, so it's similar, 15, 20%, and then here 70% in grade 4. So it is classic, I know, because they have a very, very well developed nuclear medicine group in Washington, and they have done many, many papers on this. So they're very, how can I say, invested in trying to look at better parameters to predict or try obstruction and therefore surgery. So I believe that that's why they rely and they have very accurate measurements, and they're able to maybe then have a lower percentage of patients with grade 4 needing pyeloplasty. In other centers where sometimes the renal scan is not that precise and there is a lot of variability, then you have to rely more on ultrasound parameters or other parameters, and then this may lead to an overindication or being more, how can I say, inclined to do an operation with the fear of losing function over time. So as I mentioned before, the third grading system is the UTD, which means urinary tract dilation grading system, which is a combination of the SFU and with the AP diameter, and trying to incorporate the ureter and the bladder abnormality, so you could have a whole picture of that patient to try to predict and stratify the patients in 3 risk groups. So the other advantage is that mainly the AP diameter that we see that can be used antenatal and postnatally, the SFU has most of the time being used postnatally. So the UTD now has a specific guidelines, or at least recommendations for the prenatal part and also the postnatal assessment. So as you can see here, less than 10 millimeters, a postnatal ultrasound is considered normal. So that's very important because you see and you face several reports from radiologists and pediatricians and your colleagues asking for what should I do with this patient? The patient needs an ultrasound, VCUG. Should I put the baby on antibiotics when the AP diameter is 9 millimeters, 8, 7, etc. Because this will still be considered hydronephrosis, especially with the better resolution of ultrasound machines. So it's important to know that less than 10 millimeters is normal, it's physiologic, and nothing needs to be done. So these are the two ways of seeing the UTD grading system, the prenatal presentation and the postnatal. So in terms of the prenatal, I'm gonna attend, because I think that's the important part, especially in the third trimester. So after 28 weeks, anytime you have that AP diameter greater than 10 millimeters, see, it's consistent with the previous ones that we've seen, but they provide here more information. So if you have this, plus you have the calyceal dilatation, or the parenchyma is thin, or you have abnormal ureters and bladder and oligohydramnios, this means that this patient has an increased risk, and then it has been labeled as UTD A2 and 3. Postnatally, they define in 1, 2, and 3, so this is a bit different from the SFU, which would go from 1 to 4. But sometimes it's easy to make an association. I'll give you guys a rule of thumb. So the SFU 4 corresponds to UTD 3. The SFU 3 corresponds to UTD 3. Let's go again. SFU 4 corresponds to UTD 3. SFU 3 corresponds to UTD 2. And SFU 1 and 2 will correspond to UTD 1. Okay, so as you see here, why? Because we're talking about the same thing. When you have an AP diameter between 10 and 15 millimeters, so only central dilatation, as we saw in that diagram from Max Mazel's, just the dilatation of the central dilatation of the pelvis, this is low risk, and patients probably will not develop UTIs, they don't need antibiotics, and they will not need any ultrasound or VCUG. So when you have now the AP diameter greater than 15 millimeters, but you have now peripheral calyceal dilatation, so the calyces are dilated, and here is the difference from the SFU. If you have this or abnormal ureters, just by having abnormal ureters, you already upgraded to UTD2, intermediate risk. And the UTD3, I mean, same thing, peripheral calyceal dilatation, parenchymal thinning, but now we incorporate the bladder and the ureters. So how do we manage these children? And I think the important thing is this. There is a likelihood, as I mentioned, of antenatal resolution of those conditions. 80% resolution when it's between 4 to 7 millimeters in the second trimester, and less than 15% resolution when it's 9 millimeters. So again, those numbers are important. I think this I'm talking about second trimester. So this will be a little bit more specific for centers who have what we call prenatal clinics between urologists and nephrologists, that they will do this follow-up and counsel the mothers or the pregnant women, and sometimes the obstetrician. So the third trimester ultrasound is the one that will determine the resolution they need for postnatal evaluation. So I think that's the number that is very important, greater than 10 millimeters in the third trimester, and this sometimes will be an exam question. So in terms of antenatal evaluation, we saw it here. So let's talk about the post-natal management. So patients, and here I apologize, but it's not my fault. I think some guidelines are there, they are outdated. And what has happened is that you probably have seen in your own institution, some of the staff in pediatric urology are not using or following these recommendations. So here we have the following criteria. Patients who have UTD prenatally, A2 or 3, what you have to do. You have to repeat that ultrasound every 4 weeks. At least that's what we do in our institution. And after birth, you have to order an ultrasound after 48 hours. The patient usually are not discharged home immediately. And normally all these patients are seen by either pediatric nephrology or urology. So those who have, in my institution, we're not looking too much at the low risk group. And I think obstetricians, they are managing this. We're not too much, because they told us that it was not, they are overwhelmed with those patients. So we could not provide, they thought was not feasible to refer all these patients who have minimal dilatation at the second trimester to pediatric urology. So for us, our main cutoff time is 28 weeks after the third trimester, if it is greater than 10 millimeters. So we're kind of seeing those patients, which will be in keeping with the UTD, increased risk A2 to 3. So just for whenever we talk about that, I think you guys know this, but it's always good to refresh. The amniotic fluid is primarily from fetal urine at 16 weeks of gestation, and then fetus, male fetus with severe bilateral hydronephrosis and oligohydramnios, they should be assumed to have posterior urethral valves, or maybe we should say lower urinary tract obstruction, because this could be caused by erythroatresia, a pruning belly syndrome, or something even something different that would be causing some outlet obstruction in severe cases. So it's important to know that if we're able to restore that amniotic fluid, this will lead to the lungs maturation and then or development, and therefore renal development as well, because we need the kidneys need the amniotic fluid to develop. So what else? Oligohydramnios after 27 weeks has favorable outcomes. Why is that? Because at that point the lungs are mature. So these babies, what can happen is that they are delivered and they will be able to breathe, or they need ventilators, but they'll be in an intensive care unit, and they will survive. So therefore, we need to be careful and then very selective when we talk about antenatal intervention. So usually speaking, this was something that was very popular during the late 90s and 2000, and then has dropped a little bit in popularity, because some of these interventions are associated with morbidity, not only for the mother, but also for the fetus. So usually it should be considered when indicated in the early second trimester. According to some textbooks, this overall need of 1 in 60,000. It depends. I think it depends how well and developed and trained is your high risk obstetrics group. And then this varies from institution to institution. So it's very important to look at these findings, which are the dilated bladder, the presence of hyperechogenicity or cortical cysts in the parenchyma, and the corticomedullary differentiator, if it's very thin or not. So whenever we suspect of a LUTO, a lower urinary tract obstruction, so then usually these patients have to be assessed by a multidisciplinary team, and then usually we're dealing with either pruning belly syndrome, erythroatresia, and valves. And then if indicated, there are some parameters. I think this is beyond the scope of this talk, but again, the two main interventions will be, which is at least in my institution, the vesicoamniotic shunt, and then especially in places like in California that you guys are very advanced, and then also in Boston and other centers, you can do laser ablation and fetal cystoscopy. So they do fetal surgery in Philadelphia and trying to address these issues. From a urological perspective, what is important, and sometimes you see this in exams, is that a fetal intervention will improve the perinatal survival, and, but at an expense of 40%, 30–40% of risk of complication, as I mentioned, and depending on the institution and papers, this can be less or more. No long-term impact on renal function so far, and we have had some real nice randomized studies that have shown that so far. So let's talk about postnatal evaluation. So it's important to do a clinical exam. The first thing that is going to be ordered, again, because it's non-invasive, is ready, available, it's right there. It's a renal bladder ultrasound, can be done at any time of the day or night. Later on, we'll talk about the indications for VCUG that have been changing. You may or may not need to do a renal scan in the first few weeks, usually 4 to 6 weeks. And those other tests is only in complex situations, and some of them, they're almost never being used anymore. So what is the first thing that it's important is the timing of the first renal bladder ultrasound. And then I usually, it's controversial, but again, one thing is for sure, most institutions recommend waiting 48 hours before getting the first renal bladder ultrasound. Why is that? Because there is a tendency to underestimate the hydronephrosis because of the initial dehydration and the oliguria of the fetus or the baby, or the intravascular depletion. So sometimes you can have a patient with even grade 3 or 4 hydro that it shows that it's grade 1 or 2, and then you may be placed in a path of follow-up and management that is different than what you used to do it. Of course, this is not valid for those patients that have high suspicion of posterior urethral valves. Then the ultrasound is done on the first day. Obviously can be repeated later if needed. But most of the time, those babies have other conditions that will require that they be admitted to NICU because of electrolyte imbalances, or they have a really severe hydronephrosis. They are not voiding properly. They'll require a catheter, etc. So there is an agreement that patients who have SFU grade 3 and 4 require more frequent postnatal ultrasound than those with grade 1 and 2. So this is actually, in our institution, we follow patients with grade 3 and 4 at least 3 to 4 times in the first year, every 3 months, as opposed to those with grade 1 and 2 that we usually get one ultrasound and then we discharge them, because most of these patients have physiologic hydronephrosis, which, as we have shown in a few studies, resolves spontaneously. So that's important to note, because depending on the severity, the approach and the management will be different. The VCUG. So you see that most of the guidelines is still there. Some of them will recommend ordering VCUG. So just for the residents, to give them some historical perspective, when I started training, all the patients, and this was like 20 years ago, all the patients would require VCUG with prenatal hydronephrosis. And then this, of course, has changed. The reason to do a VCUG is because in the past, we were very concerned about or trying to identify patients with vascular urethral reflux, because we had to prevent those patients from getting an infection, to try to save them from having renal scarring and damaging those kidneys. We know that this is not how it occurs, and therefore the necessity of trying to identify those patients who have vascular urethral reflux has decreased substantially. So, but it's always important, if you do a VCUG, try to look at other aspects as well, such as the spine, to see if the patient has the vertebrae are okay, like, the sacrum, if it has a spinal bifida or something like that, constipation, stones, etc. And also, it's very important to always use a feeding tube and not a balloon catheter, because this can hinder the test. You can actually get some urine when you're doing the test, because they're catheterizing the baby. I usually try to fill with gravity until the first void, and try not to overestimate. So try to calculate the capacity of the baby, because you can have some false positive results. And always waiting, and sometimes if you can get it, a delayed image, because you can assess for some UPG obstruction or UVG obstruction. So as you mentioned, there is a complex relationship or a lack of a relationship, I would say, between vascular urethral reflux and antenatal hydro. So some studies have shown this to be 4 to 40%. Because again, it doesn't depend. People will order, if you have guidelines that have recommended everybody with high grade requiring vascular urethral reflux, then your incidence of VUR may be different than if you are ordering VCUG for all patients with hydro or never. So I put this sad face here, because even now, as according to some guidelines, if you used to have severe hydronephrosis grade 3 and 4 or UTD 3, this was mandatory to have avoiding cyst erythrograms. And I think what is mainly most practitioners are doing is trying to be selective based on if you have isolated hydronephrosis versus hydroerythronephrosis. So if the ureter is dilated and you have bladder abnormalities, by all means, you can order your VCUG. But if you have just simple isolated hydronephrosis, we have shown in studies like that, the incidence of the yield of vascular urethral reflux will be 10 to 11%, and most of those cases will be low grade. So therefore, in our institution, we're not ordering VCUG in those cases anymore. Secondly, once you do that and you find no VUR and you have a patient with severe hydro, the next test that needs to be ordered is a renal scan. And this can be done either with the TPA or MAG3. The main difference is that the MAG3 has extracts more of the tracer in the proximal tubules than the TPA. The problem with MAG3 is that the images are not well defined, but it does show the differential renal function and can assess the drainage of the kidney. And some textbooks will consider 20-30 minutes as being an indication for or a sign of obstruction. We know that this is not like pathognomonic, and it has to be interpreted with a lot of caution. Other people like to look at the curves to see if a patient has an ascending or a plateau curve. This actually means obstruction. Others like to look at the count, how many particles are counted, and then they do this to see if there is a subtraction. And it's a test that has several variables. I have to be a well-tempered renogram with a catheter, and the Lasix has to be administered usually at 20 minutes. So for patients to see what's going to happen with the drainage, and then several other factors, hydration status, the function of the kidney, etc., etc. So I try to mention this in the protocols that there is a lot of variability, and that's why when you're trying to use this sole criteria to indicate surgery may be difficult, because you can have different results based on different institutions and protocols. But basically, the criteria for intervention solely based on renal scan would be differential renal function less than 40%, IT-half time greater than 30 minutes, and significant retention of delayed imaging. Sometimes you have no drainage or an infinite curve going up, so that's pretty convincing that it's obstructed. Patients with low-grade hydronephrosis, that's an important thing. If you're in doubt which patients need this test, but at least we know that some do not need it. And if they have grade 1 or 2 or UTD 1, they do not need to be investigated and no renal scan. All those tests, I think we can just scan, but sometimes, especially in the US, we're using more and more what we call magnetic resonance, the MRU, which is you can give the detailed image of the anatomy, and also depending on the protocol, you can assess the function the way they perform the test. So what about antibiotic prophylaxis? So this is another controversial topic. So historically, antibiotic prophylaxis was given empirically for all babies with prenatal hydro in the first 18 to 2 years of life. And then, but this was based on low level of evidence and then variability from practice patterns and recommendations. So right now, and this has been evolving over the past 10 to 15 years, what have we tried to do? We try to identify subpopulations that have a higher risk of UTI or renal deterioration, and therefore we thought that those patients would need or benefit from the antibiotics. So the role of a CAP that we call continuous antibiotic prophylaxis is still controversial, and then some guidelines have a low threshold of indication or not. So the most common ones would be amoxicillin, cephalexin, and trimethoprim here. Important that in the US, it comes with sulfa, so Bactrim cannot be given to those babies in the first 3 months because of the risk of kernicterus. So that's why sometimes, at least in Canada, we can manipulate just the TMP component. So we publish or review the literature about this issue of antibiotic prophylaxis for patients with prenatal hydro, and we saw this, that the rate of UTI was 4 times higher in patients with high grade versus low grade. And in terms of numbers, was around 14% in those who had low grade versus almost 30% in those with high grade hydronephrosis. One thing that was interesting is that when we just pulled patients that had low-grade hydro, giving antibiotics or no antibiotics, the rate of UTI was the same. Therefore, we think that that was an important contribution, is that, okay, for low-grade hydro, patients do not need antibiotics. We need to see if everybody who has high-grade needs it. And as studies have been reported and published, we have seen that even for the high-grade population, not everybody needs. Probably only those who have dilated ureters, those with isolated hydronephrosis, the UTI rate is low, usually less than 5% according to even multi-center series. So we reviewed and updated that systematic review a few years back, and it showed similar results, saying that patients with a severe degree of dilatation had a higher risk of UTI, especially those with a primary obstructed megaureter. So how do we recommend, what do we suggest or recommend for the time and frequency of monitoring? So this is, again, based on the consensus statement that I'm trying to tell you. So SFU grade 0, you can forget, patients can be discharged, they'll be asymptomatic, risk is very low, no need to follow up. Grade 1 or 2, some people repeat an ultrasound in the first 6 months, but after that, especially if the AP diameter is less than 10, they can be discharged and don't need to see annually. Those who need monitoring are those with grade 3 and 4 or UTD risk group 3. So again, ultrasound after 2 days of life, and then after that you can monitor depending on the severity. Some of those patients, if they have dilated ureters and blood abnormalities, need VCUG, and if the VCUG does not show vascular reflux, then a renal scan is indicated to see if look at the renal function, differential renal function, and if there is any indication that a suspicion of obstruction based on the drainage time and the curves. So we try to look at some of these things about surveillance. So we look at the classifications, SFU and UTD categories. And as you can see here, over 2 years follow up, what you see here is that there is resolution of hydronephrosis. Grade 1 resolves in 90%, grade 2 in 73%, 50% grade 3, and only 30%, 35% in grade 4. So the UTD was followed similar pattern of resolution, but the numbers were a bit different because of not everybody, when they have dilated ureters, these upgrade their category to UTD2, even though if you can have just a dilated renal pelvis and not grade 2 as in the SFU. So that's why the numbers don't match completely, because of that small variation between the two classifications. So others have shown, this is a nice study done by the group in Virginia, led by Tony Herden, and then this is the registry of hydronephrosis that we also are a part of it. And then this group showed that again, 100% of patients with SFU grade 1 and 90% of grade 2 resolve completely. So the message for the residents is this, that patients with UTD grade 1 and SFU grade 1 and 2, these are not considered pathological conditions. These are physiologic patients that will not have a high risk of UTI. They will resolve spontaneously and can be discharged and don't need to be followed by ultrasounds every 6 months. In terms of surgical intervention, just a quick note that is important. I think these are the strong indications with loss of function, more than 5%, or a differential renal function less than 40, worsening of the drainage time. So if you do repeat scans, worsening of hydronephrosis, every time you do AP diameter is getting bigger, SFU is getting worse, or the parenchyma is getting thinner. And then of course, if they have flank pain, vomiting, or in my indications, I think UTI comes here, but because those patients are very seldom develop urinary tract infections, so I think that's not a important factor for indication of pyeloplasty. So this is the recommendation from the consensus statement on the UTD classification. And you can see here, I mentioned a lot of things are written here as discretion of the clinician. So I would argue that this now we need to get an update. And I think Tony Herden, myself, and others who are working on that, I think this is going to be an X, and these patients in the new update will come that this does not need to be followed, does not need any can be discharged to be seen by a family doctor or a general practitioner, but they do not require a specialist. And these patients will do well because this is physiologic. I think the main issue is in patients with UTD 2, the intermediate risk. I think here the VCUG, I think the main issue is that if you have isolated hydronephrosis, no VCUG, maybe dilated ureters, yes for VCUG, antibiotic prophylaxis, again, the same thing, not for those with isolated hydro, maybe for those who have dilated ureters because the risk has been shown in papers to be higher. And patients with grade 3, those are the ones that get VCUG and antibiotic until we have a final diagnosis. So this is it's a passionate topic for me, so I think I have spoken too much, but I would like to finish showing like this is an algorithm that was published in the Canadian Journal of Urology from the guidelines with our colleagues from Quebec. So that's how we do it. I think we change each service has a little bit of different thing, but again, following those recommendations, if the AP diameter is greater than 15 millimeters in the 3rd trimester, so this puts you in the high risk or severe hydro category, or SFU grade 2 and 3, the first one. So you have an ultrasound in the first 2 weeks of life, and then those babies are on antibiotics. See, but I think it depends. I don't use antibiotics anymore, only when the ureters are dilated. So you do repeat this ultrasound if it shows SFU grade 1. So then what happened? So these patients get one ultrasound and can be discharged. If it's grade 3 and 4, these groups here, according to these guidelines, they're still doing VCUG, and then VUR, you manage vascular reflux, no VUR, then you have the LASIK renal scan, and then you can go from there because you're trying to decide if that patient with a UPJ or like will need surgery or not. So I just put it here for you guys to illustrate a clinical scenario that you see very quickly. A 40-day-old boy that I consulted NICU for hydronephrosis on the left side, prenatal diagnosis, very healthy. So that's the ultrasound. So this, you see it, so like right this, what you see, it's a bare paw sign, parenchyma is thin, because you don't see that as we shown in the algorithm or that exercise. And then you see whenever you see the peripheral calyces communicate with the central cavity, then this means that this is hydronephrosis. If you have independent cysts that they do not communicate, this could be a multicystic dysplastic kidney. So this is a patient with a grade 4 hydronephrosis according to the SFU, or a UTD P3. So you don't see any ureter. So this is more in keeping with a UPJ obstruction. So the questions in exam will be, what's the next step? So some people, according to guidelines, may still order VCUG in those cases. Is not wrong. The chance of finding associated VUR in those cases will be around 10%. But most of the time, the next test will be a MAG3 renal scan, and then you can manage those patients either surgically or not surgically, depending on your institution protocol. In our case, we felt that patient, after having 2 ultrasounds and the renal scan that showed an obstructive curve, had this investigation, which shows we like to do a retrograde pyelogram before doing the pyeloplasty at the same time. We see again the same image, and then you see the narrowing of the UPJ with this a pathological ureter, and then this is a classic finding of UPJ obstruction. So we did the baby was like 4 months old, and we see that narrowing part and plus a kink, and this was excised, and then a pyeloplasty performed, and the patient did well. So I think due to the fact that this is a passionate topic for me, I think I would like again to thank I would like to thank the UCSF for the great opportunity to present to the residents, and I'm open for questions because this is a very extensive topic that 1 hour, 50 minutes is hard to cover. Thank you.
Hi, Dr. Braga. Thank you for the talk. I don't think I see any questions on the chat for tonight.
Okay, so maybe people are sleeping. Not very good talk then.
No, I think it was very good. Maybe no question.
So, Kristen, can I
think Dr. Braga, like if there's no questions, we can end the talk early and give people more time on their day. Thank you so much for giving us the talk, Dr. Braga. Thank you, Ding.
Bye-bye, guys. Thank you.
Oh, there's actually a question on the chat.
Yeah, I see it. It's from Bruce. He says, "Hi, Dr. Braga. Does it matter whether you manage concurrent VUR versus UPJO first?" Ooh, classic question.
So if I understood well, he's asking if you, during your investigation, you find that the patient has what he suspects to be a UPJ obstruction plus with concurrent vascular reflux. That's the question?
Yes.
Yeah, so that's a classic and it's important. So the residents, if there are few residents there, that's an important question for exams. Whenever you have a setting that you have a VUR and UPJ obstruction, once you have defined that, you're always going to manage obstruction first. Obstruction is the one that is going to affect your kidney, it's going to damage the kidney, cause parenchymal thinning, loss, reflux. As long as the patient is like not having like infections, recurrent infections, you tend to have like a patient that is not going to get the kidneys damaged unless it is very secondary VUR due to neurogenic bladder or posterior urethral valve. So whenever you have a setting that you have established that the patient has vascular urethral reflux and in the setting of a UPJ obstruction, and if you have obstruction, then your patient will need a pyeloplasty. So you do the pyeloplasty first, you fix the obstruction, alleviate that kidney, and then most of the time in my hands, we have never had to do any surgery to fix the vascular urethral reflux. Those reflux are usually low grade, grade 3, and they resolve spontaneously without presenting any problems. If the patient, especially if it is a girl, has issues with recurrent infections, you can always inject a deflux, an endoscopic procedure. It's minimally invasive, and but the kidney will be established and unobstructed and then developing normally.
Thank you.
All right. Well, I guess I have to do it again. Thank you again, Dr. Braga, for spending your time with us. And thank you again, Ding, for moderating this talk.
Bye-bye, guys. Thank you.
Bye.
All right. Thank you.